So what drove us to perform this study is that invasive procedures for chronic pain have come under increasing scrutiny because of the rising rates over the past 2 decades, which have leveled out only because of payer pushback in the form of prior authorization and stricter criteria, mixed results or negative results in some of the highest impact studies, and the failure of interventional procedures to reduce surgery rates or opioid use. My name is Stephen Cohen. I'm the Chief of Pain Medicine and a professor at Johns Hopkins School of Medicine and the Uniformed Services University of the Health Sciences. And I'm here with 4 of my co-authors to discuss our article entitled Nonorganic or Behavioral Signs and Their Association with Epidural Steroid Injection Outcomes and Psychiatric Comorbidity in Cervical Radiculopathy, which will be published in an upcoming issue of the Mayo Clinic Proceedings.
I'm Dr. Sharon Zhao. I'm the Chief of Interventional Pain in the Veterans Affairs Medical Center, Washington, D.C.
My name is Eric Wong. I'm an assistant professor at Johns Hopkins University in the Department of Anesthesiology and Critical Care Medicine, and I serve as the program director of the Pain Medicine Fellowship.
Hi, I'm Tina Doshi. I'm an assistant professor at Johns Hopkins University.
Yeah, my name is Jian Moon. I'm an associate professor in the Department of Anesthesiology and Pain Medicine in Seoul National University College of Medicine. I'm a chief director in Pain Management Center of my hospital.
Personalized medicine is an emerging practice in which a patient's phenotype, diagnostic tests, and maybe in the future genotype are used to guide treatment. When properly used, precision medicine can favorably alter the risk-benefit and cost-effectiveness ratios. But diagnostic tests can be risky by themselves and expensive, and for most, predictive values are not known. Genotyping is expensive and takes a long time, and while it can be helpful for certain types of medication management, we don't know whether they can be used to select patients for procedures. Non-organic signs, also known as Waddell signs, have been used for over 40 years to identify patients who are likely to fail low back pain treatments and who might benefit from psychological evaluation. Although there are numerous studies evaluating the effect of non-organic signs on low back pain outcomes, including by this group, there have been none for neck pain. And the handful of studies that have studied cervical non-organic signs have focused on testing reliability, not validity. Non-organic signs can theoretically serve as an excellent predictive tool because they're quick and easy to perform, they're free, they don't require standardized equipment or skill sets. So we set out to adapt cervical non-organic signs based on the extant literature, validate them in a tiny pilot study, and came up with 9 signs in the original 5 categories. We sought to determine their association with cervical epidural steroid injection outcomes because epidural steroid injections are the most common procedures done in pain clinics worldwide. We did this by using an observational cohort design and logistic regression models to determine the association between non-organic signs and categories and procedural outcome. A successful procedure was defined as a decrease in the average arm pain score of 2 points or greater at 1 month and a score of at least 5/7 on the patient global impression of change scale. We hypothesized that more non-organic signs would be associated with poorer outcomes and maybe higher co-prevalence rates of coexisting pain conditions and psychiatric disorders. Dr. Moon, can you discuss the prevalence rates of the different cervical non-organic signs that we found?
Yeah. Thank you for asking me. First, one of the main findings of our study was the prevalence of non-organic signs. So we included 78 patients in the study, and among them, 29% had nothing of non-organic neck signs. However, 21% had positive signs in at least one category, 10% had in 2, 21% in 3 categories, 10% in 4, and 9% in all 5 categories. The most common positive category of disturbances was non-correlative tenderness, followed by sham stimulation, regional disturbances, overreaction, and pain from distraction. When we found each specific signs in 5 categories, the most common was superficial tenderness in 44% of our patients, followed by non-anatomic tenderness non-anatomic sensory disturbances and pain with passive rotation, which were found in each 32%. So also we found that pain from downward head pressure, non-anatomic motor disturbances, and paradoxical response to distraction were also very common in over 20% of our patients. However, relatively, the prevalence of nonverbal overreaction and non-anatomic motor disturbances were low, which were reported only in 15% and 13% of our patients respectively.
Thank you, Dr. Moon. Dr. Doshi, would you be able to discuss for the audience the association of non-organic signs with demographic and clinical characteristics and the association with clinical outcomes?
So at the primary endpoint of 1 month, the mean number of non-organic categories present was 2.5 in individuals with a negative treatment outcome, which was significantly higher compared to the mean of 1.1 categories in those with a positive treatment outcome. So patients with negative treatment outcomes had significantly higher prevalence of all non-organic categories except sham stimulation. The categories most strongly associated with negative outcome were regional disturbances and overreaction. Both categories had a greater than 50% prevalence in the negative outcome group compared to a less than 20% prevalence in the positive outcome group. Similarly, when we broke those down by individual signs, the mean number of positive signs was 3.4 in those with negative outcomes at 1 month, compared to 1.3 signs in those with a positive outcome. The individual signs that were most strongly associated with negative treatment outcome were non-anatomic tenderness and sensory disturbances. And for both signs, there was a 50% prevalence in the negative outcome group compared to just 11% prevalence in the positive outcome group. We found the same pattern for treatment response at 3 months. In our univariate logistic regression analysis, we found that each additional non-organic category present out of the 5 corresponded to an additional 44 to 50% decreased odds of a positive treatment outcome at 1 month and 3 months respectively. Each additional non-organic sign present out of 9 was associated with 35 to 41% decreased odds of a positive treatment outcome at 1 month and 3 months respectively. And then in our exploratory multivariate analysis, we controlled for study site, patient age, presence of multiple comorbid pain and psychiatric disorders, disability, depression, anxiety, sleep and somatic symptoms. And we found that only the number of organic signs or symptoms or categories, the presence of a herniated disc, and baseline neck disability index score were significantly associated with a treatment outcome. Increased non-organic signs and baseline neck disability score were associated with a greater odds of a negative outcome compared to the presence of a cervical herniated disc, which was associated with a positive treatment outcome. We found very similar patterns for our secondary outcomes as well. So compared to patients with 0, 1, or 2 positive non-organic categories, those with 3 or more had significantly better mean improvements in average neck pain and patient global impression of change scores.
Thank you, Dr. Doshi. Dr. Zhao, can you tell us a little bit about your patients and some of the challenges that you had conducting the study at the VA?
So the hospital where I work is one of the 171 medical centers in the Veterans Health Administration. So we have over 9 million veterans enrolled in the VA healthcare program. In the past, the data from the 2010 to 2014 National Health Interview Survey showed that veterans with neck pain were more likely to report severe pain. Now, compared with civilians, the rates of post-traumatic stress disorder, depression, and suicide are high in the veterans. It was estimated that 1 in 3 veterans had at least 1 mental health diagnosis. So more pain, more severe pain, and the presence of comorbid psychological factors make pain management in our patient population very challenging. So this study is very helpful for our future treatment for our patients.
Thanks very much, Dr. Zhao. Dr. Moon, can you talk about the patients that you saw at Seoul National University and some of the challenges?
I think that the medical system is very different. So, I mean, the South Korea's medical system is totally different from the system in the USA. So, I usually see about a lot of patients, about 80 patients, very huge number, in my outpatient clinic 3 daytimes a week. So things are very busy here, and we have a very efficient system, medical management system with teamwork. So most of my patients have chronic intractable pain because I'm working in a tertiary national university-based hospital. So I have a lot of failed back surgery syndrome patients, complex regional pain syndrome, cancer-related pain, fibromyalgia, and other very refractory intractable chronic pain patients. And we are doing several procedures every day, such as neuromodulation, spinal cord stimulation, or intrathecal morphine pump, and other very relatively conservative management, such as just scrambler therapy or trigger point injection, etc., using fluoroscopy and ultrasonography. So it is every day. I think that every day is very, it's a challenging for me to see such very severe patients in my clinic. Yeah.
Thank you very much, Dr. Moon. Dr. Wang, would you be able to tell the audience about some of the limitations in the study?
Unlike for lumbar spine pain, standardized categories and physical exam maneuvers for non-organic signs in the cervical spine have yet to be defined in the literature. Therefore, some of the modified exam maneuvers that we used, such as gentle pressure on the head for generating sham stimulation, have yet to be validated. Also, although every patient was evaluated by at least 2 examiners, this assessment was not done independently, so we could not quantify inter-rater reliability. In addition, we only assessed pre-procedural non-organic signs, so this study did not assess whether these signs might have improved or resolved post-procedurally. Lastly, we examined over 20 different variables in 78 enrolled patients. The sample size might have been small enough to increase the risk of type 2 errors and not sufficiently powered to identify additional factors that might influence treatment outcomes.
Thanks very much, Dr. Wang. So to summarize the final take-home points, the better selection of patients can lead to better outcomes, a more favorable risk-benefit ratio, and lower costs. Although there are several different ways this can be done, the use of quick and easy to perform non-organic physical exam signs appears to be very promising. More research has to be done in this area. And finally, don't forget to read this article. Thank you.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.